You're listening to Medscape's In Discussion series on lung cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jacob Sands, Assistant Professor of Medicine at Harvard Medical School and physician in the Thoracic Oncology Program at the Dana-Farber Cancer Institute in Boston, Massachusetts, and Oncology Medical Director of the Dana-Farber Brigham International Patient Center. Relevant disclosures can be found with the episode show notes on Medscape.com or on the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Jacob Sands. Welcome to Season 3 of the Medscape In Discussion Lung Cancer podcast series. Today we'll discuss women and lung cancer, the Pregnancy and Lung Cancer Registry by Florez Lab, sexual health, and lung cancer screening. First, let me introduce my guest, Dr. Narjust Florez. Dr. Florez is the Associate Director of the Cancer Care Equity Program, a thoracic medical oncologist at Dana-Farber Cancer Institute, Assistant Professor of Medicine at Harvard Medical School, and the Associate Editor of JAMA Oncology. Some of you may remember that Dr. Florez was a guest on Season 1 of this podcast. She joined us for an episode on the role of cultural humility in addressing disparities in lung cancer treatment, how physicians can make a difference. Dr. Florez, welcome back to the Medscape In Discussion Lung Cancer podcast.
It is my pleasure to be here. I'm glad I was part of the renewal Season 3, so I can stop calling Netflix now. It's good.
Well, I'm excited about what we're going to talk about today because these are some topics that I think aren't discussed enough. So there's a lot to dive into. But before we dive into some of the studies we're going to discuss, let's set the stage. You see a lot of young women with lung cancer. And so can you just provide us with an overview? I think this is a population that the public finds very surprising, that young women that never smoke get lung cancer. Of course, I don't want to not include women who have smoked, but generally speaking, young women, what are the numbers on that? And what are you seeing in clinic?
Lung cancer, unfortunately, is still the leading cause of cancer death, not only in the United States, but many industrialized countries. And as the country's economy improves, lung cancer creeps up to become the number one cancer death in women. We have seen an increase in the number of cases of lung cancer in younger women. And this was first systematically reported in 2018 by Jamal et al. In a New England Journal of Medicine paper, in which for the first time in history in the United States, more younger women are getting lung cancer compared to young men. And when we talk about young women, we talk about women less than 50 years old. So more young women are getting lung cancer now than men. And this is irrespective of tobacco use. So the incidence has changed in patients that have active tobacco use and patients that don't have a history of tobacco use. And we're estimating that around 18% of the cases of lung cancer are happening in younger patients. So these are patients less than 50. Out of that 18%, 2/3 are women. And one of the challenges with this is that there is still a lack of association between lung cancer and women. So there is significant delays in diagnosis for these younger women as lung cancer still remains as a disease that affects older men. We just conducted a study in which younger women take 3 times as long to be diagnosed compared to younger men. And that comes with the consequences of affecting survival because it's a stage at diagnosis. These younger women don't qualify for lung cancer screening because they don't have the age or the tobacco exposure. And I call this generation the sandwich generation because they have the children responsibility, their own children, and they're also caregivers of their parents. So it's a sandwich generation. And I think you and I are part of this generation. We have responsibility at both sides. So often health for these women is put as a lower tier. So more and more younger women are coming to my clinic. And unfortunately, we don't see the media covering as much as they should.
We're going to dive into some of the more quality of life topics that I don't think get addressed enough. And I'd like to start out with the Shaw study. I want to applaud you, one, for coming up with the topic and studying the topic, but getting funding and actually getting results. It's pretty amazing that we have so much to discuss. But give us an overview of the Shaw study, the design.
So the Shaw study is a sexual health assessment in women with lung cancer study. The study was first conceived in 2019, and we designed the study in conjunction with two amazing patient advocates, Jill Feldman and Ivy Elkins, the co-founders of EGFR Resistors. We also worked very closely with the GO2 Foundation to create the study. So this is a cross-sectional survey study that was designed and modified because we are about to launch the study and then the world shut down in 2020. But that was a good learned lesson. The lung cancer registry of the GO2 Lung Cancer Foundation has thousands of patients. So we housed the registry there so patients felt familiar with the study because, as you mentioned, it's a subject that is underexplored. So we needed to work with patient advocates and our organization to get that trust of patients feeling comfortable talking about vaginal dryness, anal pain, lack of orgasms. That's something that, let's be honest, this is probably the first podcast that we're talking about it. So we housed the survey there, and it was open between June 2020 to June 2021. And the eligibility criteria included patients older than 18, self-identify as women. They needed to be fluent in English and have a lung cancer diagnosis within 10 years. So we have patients that included stage 1 to stage 4. So that's the overall design of the study that was designed and then modified due to COVID.
And what was the total number of patients that you're looking to survey? And what was the success rate like? I mean, the fact that you did this in a year suggests that people were interested in and participated. And then were patients just participating from home? They'd essentially submit these to the registry within the GO2 Foundation.
Included in the analysis was 240 women. We did had around 10% of patients that would start the survey or the questionnaire and we couldn't complete it. So they were not included in the analysis. We also have some patients that started the survey and didn't agree with some of the questions. So they also withdraw their consent. There's something important to mention about these researches. As we become more comfortable talking about sexual health in patients, we feel more comfortable too. There was a comfort level there that some patients reported didn't have. But overall, nearly 250 women completed the survey. We're going to talk about some of the quantitative data, but we have a lot of qualitative data that these women felt comfortable writing paragraphs about the issues with sexual health and why they consider it important. But the number one message, besides what we found in the results, is they were very glad that somebody cared about their sexual health. That was the overall message. Thank you for doing this. I finally told somebody about my vaginal dryness. I'm finally having a self-assessment of how I can improve my sexual health and how I can talk to my oncology team.
You know, I often say to patients about various topics, whether it be their own concerns about scheduling or something, that we are at work and they're living their lives. And so we need to find ways at work that we can help them with such important things as living their lives. What you're describing there really falls into that very much so, is something that's really impacting their quality of life that is not related to their scans or something that we're rushing into the room and hustling through, but actually something that requires them having a comfort level to speak about it, and also a medical team that has a comfort level and a willingness to really hear it and sit down and address these topics with them. And this is part of why I'm so excited to talk about this, is I don't know that there's really been a ton of direction on that, even for those who are really willing and committed to their patients. So before we get into the quantitative stuff, which you're right, I do want to get to, but you've enticed me so much about the qualitative stuff. Let's start there. You mentioned their enthusiasm and appreciation for the fact that this is being addressed, but anything more within those qualitative paragraphs that you were describing that you'd like to highlight?
I think that brought more understanding about sexual health in women as a whole and women with lung cancer particularly. And it's a gamma of things that are affecting their sexual health. And many of them interact. So their mental health, how their scans will affect their willingness to engage in sexual activity is all correlated when it comes to sexual interest. You know, if you're doing poorly, you're less likely to be motivated. So it shows how our patients are different aspects that all come together and interact like an ecosystem. Relationships with their partner were also significantly brought up in the comments because cancer brings a lot of stress. And another thing that I would never expect was financial health is linked to sexual health. if you don't know how to make ends meet because cancer is so financially toxic, we got in some of these responses, this is unpublished, but in general, that when they were facing significant financial toxicity, it also affect the relationships at home and affect overall the willingness to engage in sexual activity. So that's what we see vaginal dryness as a separate thing, but it's actually the result of many factors that interact for our patients. Before I talk about the results, it's very important that we ask about sex activity or sexual activity with themselves or with a partner. And that also not only included intercourse, included oral sex, anal sex, any type of manipulation or self-stimulation, and toys as well. Because in order to understand sexual health, we understand that's on a spectrum. Cuddling is part of intimacy and is part of your sex life as well.
So let's dive into some of the quantitative results then that you were mentioning. What do you see in all of that and beyond?
So what we found was very sobering. 77% of the women that participated in the study have moderate to severe sexual dysfunction. There's barely any studies that we show you such a large number on the moderate to severe. So what it means moderate to severe sexual dysfunction? It means little interest or negative physical consequence to get engaged with sexual activity. So these women will think about their sex life almost daily and the spectrum of moderate to severe sexual dysfunction. Also, on top of that, the ones that were engaging in sexual activity, 48% reported minimal satisfaction. So we have a group that didn't engage. We had a group that engaged, but 48% have no satisfaction for the sex life, including self-stimulation and other ways of sexual activity with their partner. And something that was very awakening from the study is that we often treat these patients with sexual dysfunction based on data from breast cancer, right? Because that's the group that has studied sexual health more, and ovarian and cervical cancer. But in lung cancer, it was different. Shortness of breath was the third most common reason affecting our women's sex life, right? So when you look at the literature for breast, ovarian, and cervical cancer, shortness of breath is nowhere. So that's a new factor. Also, we significantly saw how your mental health was negatively affecting these patients. So that's the fourth more common factor that was negatively affecting their sex activity, was feeling sad or feeling anxious. Not only about depression, so anxiety also negatively affected. So that's why we need interventions that are tailored to women with lung cancer instead of trying to extrapolate from other diseases because their needs are different. I found it very awakening. It's like shortness of breath. Of course, right? You have one lung, one quarter of a lung. You have radiation, and some types of sex activity require lung reserve. So that's very unique to women with lung cancer.
Those are sobering numbers that you're describing and clearly helpful in hearing what an issue that is. How has this impacted your regular clinical practice? And then also, what would you recommend to others as takeaways from this and how they change or improve the way that they're caring for patients?
The second complaint that was affecting sex life was vaginal dryness. And that is an easier fix that we often think that for sexual health needs to be complicated. So I don't know if you have seen it in our cleaning room, there's a bowl full of lubricant. So that's how actually I changed my practice. Now I have a bowl full of lubricant, vaginal lubricant, and vaginal moisturizers in both of my clinics. And I bring it into the room to open the conversation. I actually, for Halloween last year, one of my patient's spouse thought it was candy. And I was like, depends how you see it. We have chocolate and mint flavor. And that just opens the conversation because we have to normalize sexual health. Sometimes there's taboo about going to sex stores. You can buy it on Amazon, but also coconut oil can be very helpful. So I have a few of my older ladies that went to Costco and went home and bought a bunch of coconut oil. So vaginal dryness, which is the second most common complaint for sexual dysfunction, is easier to fix. So that's what I changed in practice. Objectively, I'm carrying around a bowl with lubricant. You probably saw it around in clinic and wonder, is this candy? It's not.
I don't know if all of our listeners are going to want to be carrying around a bowl of lubricant, but I applaud that. And I can see how that would really help to break the ice. I imagine that the comfort level of the physician talking with the patient is going to directly impact how comfortable the patient is talking about their own sexual health. That's not to say that everybody will, and some patients will not want to. And of course, that's okay too, I would imagine. But aside from just jumping in and actually asking the questions, how would you advise listeners to determine whether or not this is a topic their patients want to talk about or comfortable talking about, and who specifically to address and what to ask?
Anybody in the care team can ask. The nurse practitioners, nursing, and the physician can ask. I told the trainees about asking with sexual health is like going to the gym. The first time you do it, you go to the gym in January, you are sore, but you develop the muscle eventually and it gets easier. And I always start with the same question. So, let's talk about sexual health. Oh, do you mind if we talk about sexual health? You would be surprised. I think 80% of the patients are like, yeah, let's talk. I wanted to talk about that. And only, I think, a handful of situations have a negative response for a patient or a partner. And you can ask the patient with or without the partner in the room. But it's usually come for a place of questioning instead of a place of like judging or anything. It's like, hey, do you want to talk about sexual health? That's very important. And also timing is important. Talking about sexual health the first day of the consult, that's not a very good use of time. After the patient has started on treatment, that's when you're going to see the real side effects, right? So after the first set of scans, I usually start talking about sexual health. Like now we know what is the new normal. Let's talk about sexual health. And I also say, do you have any concerns? And sometimes the patients may not feel comfortable telling you face to face. And I say, okay, think about it. And then in the second appointment, you address it again. And I can assure you that we have a list of things they want to talk about sexual health. And some patients think about it and then send you a patient gateway message later. We don't have to know how to fix each issue. We just have to open the door and be able to refer patients to the right place. I know a GYN. So if the patient has pelvic floor issues, I know where to refer them. And if the patient has depression, that's a way to address it too. We have physical therapists. At Dana-Farber, we have a dedicated program for sexual health and cancer. They have webinars that people can watch, and there's also materials we can provide. So we don't have to fix every issue, but I think it's our duty to bring it up. Why? Our patients are living longer. You and I have patients that have been living for years. Are we expecting our patients to not be sexually active anymore? And sexual activity has been associated with decreased pain needs, lower needs for opiates, decreased anxiety, lower needs for benzodiazepines, improve and self-esteem, decrease symptom burden, and overall a sense of well-being. So there's many benefits of sexual health. And also there is a third party that may benefit from these too and that can type the relationships when the issues are brought out. I had a patient that the spouse was so worried that he was going to break her because she had cancer. And that was it. That was the obstacle. He really thought because she had cancer, he could break her during sexual activity. So we slowly went through steps of oral sex, touch, and then they eventually got to penetration, and that helped open it. No treatments. It was just talking about, let's just do a sequential because this is the new normal and see how you feel with your new body, because now you have a new scar and with the new side effects. And that has been very helpful, but we don't have to have all the answers. And it can start with, hey, do you want to talk about sexual health? And most patients say yes.
I think that's very helpful advice. I want to talk about the next steps now.
But the first step is to get people talking. And I have been able to get people to say vaginal dryness at the World Conference on Lung Cancer. So first, go check. You and I are talking about it. The second thing is we are submitting a grant to several companies that produce and generate materials for sexual health to focus on the intervention. So these vaginal moisturizers, vaginal lubricants, to do in a matter of a trial in which will be evaluate the benefit of this in conjunction with meetings with physical therapy and a sexual health psychologist to see if it is multidisciplinary intervention, we improve what we have learned. And we are on the process of obtaining funding because we have to get money from the toys and money from here to put all this bucket of money to do this multidisciplinary intervention. But I'm very hopeful because we're talking about it and there is not a lot of competition of people studying lung cancer and sexual health. So I hope that next time when I come back for season 4, I can tell you that we got the money.
Well, this already seems like a huge success. And like I said in the beginning, I applaud you because this is an area that there really hasn't been a tremendous amount of study, and to get funding and to get results and all of that. I think in many ways, that's a great success. I want to transition to a different, but also extremely important and understudied topic. Now, you've also started a registry specifically around patients with lung cancer and pregnancy. Can you give us a bit of an overview on that and what you're collecting?
So the Pregnancy and Lung Cancer Registry is an international registry, the first one in history to be collecting cases of lung cancer during pregnancy, also pregnancy in patients that already have been diagnosed with lung cancer, and something that we call peri-pregnancy diagnosis, which is a diagnosis of lung cancer within a year of delivery or pregnancy, not all pregnancies end in delivery. So this is a result to the increased number of cases in younger women, and as a consequence, increase of cases of lung cancer and pregnancy. And all dates back to one phone call. To be honest with you, I got a phone call from a friend and say, you need to be the one helping me here. I have a pregnant woman with lung cancer. And I was like, And I searched, and what we found is this no uniform data. And a lot of the data is before targeted therapy and immunotherapy. And we also saw that some people are using targeted therapy, some people are using immunotherapy, some people are using chemotherapy. So that leads to the lack of uniform recommendations. And more phone calls like that have continued to come my way. And which is like, what do we do? I just searched the data and there is no consensus. So the registry is an ongoing effort. It has been open for nearly 7 weeks. And we already have over 20 cases, making it already the largest cohort of pregnancy and lung cancer cases. We have cases from Australia, India, Brazil, the United States, and we hope to release data every 6 months. The first data release, we hope it will be a world conference in 2024. So we can provide these guidelines to our colleagues because the problem is not going to get better. It's going to continue to get worse. And we also have patients that have biomarker positive disease that are young. They have a good response. And now they're wondering if they can get pregnant, right? So that is the ultimate goal of the registry, is to create uniform data so we can eventually create guidelines on how to treat these patients. So first, patients are no harm. And also very importantly is that termination of pregnancy is not the only treatment, because we have seen that a lot, that often these women are told they have to terminate the pregnancy. That's a woman's decision. And there are alternatives. There's chemo. There's some information about targeted therapy that's coming our way. So our patients have options when the unimaginable happens, which is a diagnosis not only of lung cancer, but during pregnancy.
This is obviously a huge topic, and I know you're just getting started. So I'm really looking forward to getting more data from that. I imagine it will also lead to many women seeking you and maybe others who are actively really involved in this. So this is really an observational at this time, just what is happening, what is the patient choosing, what are the outcomes, and you're going to plan for or aiming to release data at World Lung later this year as the first time point?
Yes. And we also are following up with the outcome of the pregnancy. So if there was a delivery, what was the outcome of the child is also very important, because when patients that are pregnant are making decisions, they're largely based on that. So we're also asking about the outcomes of the child at 6 months and 1 year for now.
How does one participate in that? Do you have a contact? What kinds of information would the team be entering?
So very importantly, this is fully IRB approved at Harvard, and there is no linkage of patient information. Patient information will not be requested. That was one of the requirements, because unfortunately we see still criminal penalization or termination in pregnancy. So we need to protect our women. So there is no patient identifying information. The information is entered by the treating physician, the treating nurse, the treating nurse practitioner, and that patient or participant is given a number, unique, but there is no way to trace back to the woman that was pregnant with lung cancer. Anybody who wants to enter a case can send us an email to younglungresearch@dfci.harvard.edu, and we will guide you and send you the HIPAA compliant link to the registry. In the registry, we ask questions like, do you want us to call you? Does the patient is interested? We have patients that actually ask their doctors if they can talk to us. So we're, modifying the IRB for that. But you can enter the case. It takes around 20 minutes per case. And then we will follow up with you at 6 months and a year to understand the outcome of the woman and the outcome of the child if it ended in a delivery.
Well, I feel like there's so much more to discuss, but that is all we have the time for today. This has been a packed episode, and I want to thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on lung cancer. This is Dr. Jacob Sands for the Medscape In Discussion Lung Cancer Podcast.
Thanks for listening to Medscape's In Discussion Lung Cancer Podcast series with our host, Dr. Jacob Sands. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on lung cancer.